Thanks for inviting me this year. My name is Allan Brett. I'm a general internist. Brandon Combs couldn't be here today. He was supposed to introduce me, and he asked me to introduce myself. So I'll make a brief, 1 or 2 minute. I trained in primary care general internal medicine back in the days when those tracks just started. I went to medical school at the University of Pennsylvania, and I did my residency at the University of Pittsburgh. And my career in academic general medicine was more or less divided between earlier at Harvard Medical School, and then the last 25 years, I was the head of general internal medicine at the University of South Carolina. And then in 2021, I moved here when both of my daughters and 4 grandchildren amazingly ended up living a couple miles from each other. So my wife and I decided to move here. I wasn't ready to give up teaching. So since moving here, I've been precepting outpatient clinics with the residents at the VA a couple half days a week. And I've been doing a fair amount of medical student facilitating in small groups and EBM and those sorts of things. And I was fortunate in my time in Boston to be involved with getting NEJM Journal Watch started. We started back in 1987, believe it or not. And then I became the editor-in-chief in '94 and still have that role, although I'll be stepping down pretty soon, but I'm going to still stay involved with it as long as I feel like it's enjoyable, which it is. I think most people know about this publication, which informs this General Medicine Year in Review. Journal Watch is a literature review publication. We come out in print every 2 weeks and in a rolling fashion online. And by the way, this past year, our medical school library did an e-subscription to this, so you can access it for free now. So if you're paying for it and you want to you can access the online version for free, not print, obviously. You go to the A to Z drop down on the library page and type in, go to J, Journal Watch, and it's right there. Okay, so this session basically is a year in review that we publish January 1st every year in print and online. And we usually end up with somewhere between 10 and 15 topics. We look at our contents for the year, identify either a single study or sometimes a cluster of studies on one topic that seems important, and occasionally a new guideline. And as you can see there, we have a very informal selection criteria, but basically we're trying to pick topics that are of interest to primary care and general medicine, outpatient or inpatient, and important landmark studies. And we pay some attention to media publicity. Regarding the outpatient versus inpatient, in most of my career until leaving South Carolina, I actually did both inpatient and outpatient, sort of a relic of the pre-hospitalist era. But starting with the pandemic, I haven't done any inpatient. So I'm feeling rusty about inpatient. So I feel more comfortable in the outpatient realm, basically. So let's go to this week. This is going to be 2 parts, this week and next week. We had 14 topics this year, and I'm going to do 5 each week. And at the bottom are 4 other topics that there's just no time to do everything and cover it reasonably. So today we're going to talk about GLP-1 cardiovascular studies, tirzepatide for obesity, steroids for pneumonia, testosterone safety, and statin choice. And then next week on the right side of the slide are the topics that we're going to cover. I'd like to do this the way I've done it the last time and many years, which is pause between each segment since they're so different rather than waiting for questions at the end. I can't possibly be an expert in all these topics, so somebody either in this room or virtually is going to know more about some of these than I do. So feel free to chime in the several minutes that I leave between them and make a comment or a question or whatever you'd like. Okay, start with GLP-1 cardiovascular studies. All right, so we have data on the cardiovascular benefits for patients with type 2 diabetes for GLP-1 receptor agonists. And the approval of those drugs by the FDA for some of them has not only treatment of diabetes, but also reducing cardiovascular risk. But the question is, what about those with obesity but no diabetes? where the FDA hasn't approved the drugs for those patients for the particular reason of cardiovascular risk reduction. So we covered 2 trials this year, both in the New England Journal of Medicine, that informed this issue. First one was called the SELECT trial. This is a secondary prevention trial. These are all manufacturer-sponsored, of course. 18,000 patients were enrolled in this trial, all of whom had either prior MI, stroke, or peripheral arterial disease. And to be in this trial, your BMI had to be greater than 27. The mean was 33. And again, no diabetes. This is a study of patients who did not have diabetes. The mean age was in the 60s. And the patients were randomized to weekly semaglutide injections, titrated as tolerated to a maximum of 2.4 milligrams of placebo. Average follow-up was 3 years, and it was a composite outcome of MI, stroke, or cardiovascular death. That composite outcome was 1.5 percentage points less over the 3 years with semaglutide than in the placebo group. You can see there it's 6.5 versus 8%. And as you know, every time we look at a composite endpoint, we should always look at the components and make sure they're all going in the right direction. Sometimes you're surprised and things go in different directions. In this case, they all seem to be trending in the same direction, favoring semaglutide. And as you would expect, weight loss was substantially greater. That's as a percentage of baseline body weight, 9% versus 1% in the placebo group. So that's the SELECT trial, secondary prevention trial. And again, right now, the FDA has not approved this drug for that purpose of risk reduction in people without diabetes. The second one is a heart failure with preserved ejection fraction trial. And the rationale for this that I kind of put together is that there's definitely a high statistical correlation between obesity and heart failure with preserved ejection fraction. So it was assumed that perhaps using these drugs might improve outcomes with that group of patients. So this is about 500 patients with heart failure and preserved ejection fraction. BMI had to be greater than or at least 30 to get into this study. The median age was 69. And again, no diabetes here. Same dose of semaglutide versus placebo. And this only had 1 year follow-up. So this is a study where it's too small and too short to look at outcomes such as death and major cardiovascular events. They use the Kansas City Cardiomyopathy Questionnaire score. And the reason I just want to spend a minute on this is that several years ago, the FDA asked makers of people who were sponsoring heart failure trials to use this tool to assess outcomes because it's a more refined tool than just rating patients by the New York Heart Association class and cruder tools, I guess. It has 23 items that include symptoms, physical and social limitations, and quality of life. The median score at baseline here was 59, and you would be right to ask, well, what does that mean? Which I always wonder when I look at a 100-point questionnaire. And it turns out that that's sort of correlated with New York Heart Association Class 2. And then you ask, what's a clinically important change, which is a whole half-hour discussion, how people decide that. Is it quantitated in some way, or is it just people making it up? Well, here, I didn't dig deeply into the weeds, but most experts feel that at least a 5-point change should be considered clinically important. Obviously, the higher the change, the more important, you would think. So this is what they found. The top panel is the change in the Kansas City questionnaire. And as you can see, higher is better here. The semaglutide group increased by about 16 points on the 100-point scale, and the placebo group 8 points. So that 8-point difference is both statistically significant and, according to the researchers, clinically important. And what's interesting is the placebo group improved by more than this clinically important 5 points as well. So something was going on in the background, whether it's a placebo response or other things that were done with these patients, that they improved over a year as well. And then at the bottom panel is the weight change. And as expected, there's like a 3 versus 13, a 10 percentage point difference in weight dropping, or almost 11 percentage point with semaglutide versus placebo. So in summary, just review these two studies and then we'll take a couple-minute pause. The SELECT study is a secondary prevention trial. This difference of 1.5% over 3 years. So 1.5 into 100 is 67. So the number needed to treat to prevent one of those outcomes over 3 years is 67. And those who know me know that I like to talk about drug costs. And I'm not intending, I just think that we ought to know what these drugs, the money that's being exchanged for these drugs that we're prescribing. And I'm not trying to do a formal cost effectiveness analysis, but surely expensive drugs in any cost effectiveness analysis, the cost of these drugs is a major input. If you look at the list price by the manufacturer, it's $16,000 a year for Wegovy, which is the dosing that was used in these studies. 3 years of that would be 50,000, right? 16 times 3, we'll round it off to 50,000. The number needed to treat was 67. So a back of the envelope calculation of the drug costs to prevent one event here would be $3.3 million, which is 50,000 times 67, if you followed my math here. Now, you could say, well, the drug companies don't get all that. And if anybody in the audience has information, I've tried to find out how much money actually ends up exchanged. You know, you have discounts and co-payments, and there's, you know, there's the drug company, there's the pharmacy benefits manager, there's the insurance company. It's very hard, but I've read that 50 or 60% of the list price ends up costing society. And if anybody has any better information, then I'd be interested. So even if this is an overestimate by 50%, still we're talking about $1.7 million to prevent one event. And it's, I'll leave to you, is that a value judgment, is that a worthwhile expenditure? By the way, that in the SELECT trial, that was on top of pretty good underlying medical therapy. If you look at table 1 in the chart, almost everybody was on aspirin and a statin and other conventional secondary prevention medications. For the STEP heart failure with preserved ejection fraction trial, the difference was 8 points on a 100-point scale at 1 year. Allegedly clinically important, too small and too short term for major cardiovascular events and mortality. And the authors of these trials, if you read the articles, they speculate what mediates the benefits here. And it's really not clear how much of it is just the weight loss alone versus metabolic and hormonal changes related to weight loss, or unique GLP effects on those receptors that are independent of the weight loss that are not understood yet. As always with these drugs, GI side effects are not trivial, and 10% of the patients in both trials stopped treatment with semaglutide because of GI side effects. And then, as I mentioned earlier, for patients without diabetes, semaglutide is not yet approved for either secondary prevention or for heart failure with preserved ejection fraction. So if one is using the drug for the obesity alone, this is sort of like an extra benefit if these trials, you know, are yielding legitimate outcomes, which I think they are. So let me stop with that one. That's the first segment, and feel free to add, subtract, or question. Yeah. You know, it's so hard. You know, I've read all these studies at least once. I didn't write them all up for Journal Watch. I wrote some of them up, you know, the original one. I don't think so, or there might have been something in a supplementary table or something like that. There might have actually been something with small numbers that weren't statistically significant because the numbers were so small. It's a great question. If other people didn't hear that question, is harder outcomes like hospitalization for heart failure in that heart failure trial, did they publish that? And I can't recall, but I vaguely remember seeing something that the tiny numbers that you couldn't really compare. Any others? Nothing in the, okay. All right, well, the second one is sort of like a related, tirzepatide and obesity. So with great fanfare in November 2023, it was on all the news outlets and everything. Tirzepatide was FDA approved to treat obesity in patients without diabetes. This is an agonist of GLP-1, like the semaglutide and its and the related drugs. And it also is an agonist of glucose-dependent insulinotropic polypeptide, abbreviated GIP. Both of those promote insulin secretion, but after that, they differ somewhat in their effects on different target organs, and they differ in their effects on glucagon. Both of the hormones are released in the intestine in response to eating. Now, we try to be careful in Journal Watch about using brand names. We don't want to be commercializing things, but when something's confusing, we feel that we owe our readers to bring it up, right? So the brand name in the FDA approval for diabetes is Mounjaro. And this new one, which is actually the same drug and the same dosing, has been named Zepbound. So there's all this marketing stuff. And there's actually some interesting stuff on the internet about how drug names get named, which you might want to look up if this interests you. But anyway, so it's the exact same drug with two different names. And what we're going to cover now are the two randomized trials that led to FDA approval. One was in Lancet in 2023, and then, although this is a year in review from 2023, one of the big ones was the year before in the New England Journal. So I threw that in here as well. One of the studies involved patients, 2,500 people with a BMI of at least 30 and no diabetes. The mean here was 38 for the BMI. And the target dose, the 2,500 were randomized into 4 groups, 3 different dosing groups for tirzepatide, 5, 10, and 15 milligrams, given once a weekly sub-Q, or placebo. And those were the target doses. It was dose escalation starting with 2.5 milligrams, but the final target differed in those 3 groups. An important point is, in a lot of these trials, in the background, there's formal counseling on diet and exercise. And that was the case in this trial, like a lot of the semaglutide trials, which doesn't happen in real practice, right? The quick thing is to prescribe the drug and not necessarily, I mean, we do, but not necessarily have the patient do concomitant counseling with dietitians or exercise programs. But this was a moderate intensity intervention where the participants met, I believe, monthly with a counselor. And at 72 weeks, that's how long this trial went. Weight reduction was slightly higher with each successive dose, 15, 19, and 21% with the 3 titrated doses versus 3% with placebo. So that's where all the hype on the media, oh, this leads to even more weight reduction than semaglutide. It's a little bit more at the highest dose. Like with the GLP-1 alone drugs, nausea, diarrhea, constipation, and vomiting were pretty common, depending on which of the 3 doses you looked at and which of those 4 symptoms. It ranged from 10 to 30% in the treatment groups versus single digits for the placebo group. So again, not trivial. The second one, remember here we're looking at it as a treatment for obesity, but this second trial with about 1,000 people were people with diabetes. And to get into this trial, your BMI had to be 27 or more. Mean A1C was 8%. The target doses here were the 2 higher ones, 10 and 15 versus placebo. So these were 3 randomized arms. And lifestyle counseling, the same lifestyle counseling that was in the previous slide. Patients were allowed to continue most oral drugs underneath this tirzepatide or alongside it, but not insulin. 72 weeks again, and the weight reduction is 13 and 15% with the 2 doses versus 3% with placebo. And A1C reduction was 2% with 2 percentage points with tirzepatide and 0.5 percentage point with placebo. So the GI side effects here and the GI side effects here were similar to the ones I showed you on the previous slide of the patients without diabetes. All right, so the summary here is somewhat more weight loss than GLP-1 alone, at least in the randomized trials sponsored by the drug companies. And this study and the studies of the GLP-1 only drugs consistently seem to show somewhat more weight loss in people without diabetes than with diabetes. And that was the case in the two studies we just saw. The 21% was in people without diabetes. The FDA-approved dosing for obesity is start with 2.5 milligrams and titrate to a max of 15 as tolerated, and the same thing which is the same as for diabetes treatment. The GI side effects are similar to GLP-1s alone. We have no long-term safety data. And as I mentioned before, I'll just repeat, the trials did incorporate structured diet and exercise counseling. And so presumably that would potentiate the effect of the drugs. And then I'm just going to tell you what the prices are again. The list prices, these are list prices. If you go to the manufacturer's websites, you have to dig around. These are actually listed there as our list price. It's a little, Zepbound is a little cheaper than Wegovy, $10.60 a month versus $13.49 a month. And I've kind of looked at this. If you would walk into a pharmacy with a prescription and say, I don't have insurance, I'll pay cash, you'd pay about this, even with the discounts like GoodRx and so forth. For these drugs, it's pretty close. You don't get any huge discount. And that's $13,000 versus $16,000 annually. So that's what we've got there. It's still early, and this was just FDA approved for this purpose in November, and I'm not quite sure how sales have gone with Zepbound in the 2 months since then. But that's the last for this segment. So anybody wants to throw in any experience already with this, feel free to comment or ask a question. Yeah. More about the exercise program and how structured it was, and were there any differences? Oh, yeah. People always ask these great detailed questions, which are important. I don't have the answer at my fingertips. It was something like, for the first half of the study, these were like, 72-week studies, there was a weekly session. I believe they were individual sessions, not group sessions. And then it kind of spread out in the latter part of the study. And the article details exactly what they did. They looked at calories, they calculated 500 calorie deficits, and they individualized it. And they were shooting for 150 minutes of aerobic exercise. The details beyond that, I don't know. And whether there were any differences in how people complied with that in the placebo group versus the drug groups, I don't know. I mean, the main take-home point here is I think that, I think all these drugs had all these studies, including the GLP-1 studies, had embedded in them, what looks like on paper fairly rigorous background counseling. Some of them with individuals, some with groups, and how that's actually implemented in busy practices is probably all over the map.
My question is, what is it? I'm just curious, what is the for the savings that come from?
I think there's no price difference. I think I wish I saw it. I found on the internet. It was almost a hilarious article about the company sitting around the table and naming these things. And I mean, it has to do with the psychology of the naming. So I read this. They said Mount Jaro had something to do with Mount Kilimanjaro, like a peak, and the Zepbound is and the Zepbound is movement, obesity bound, and Ozempic is supposed to subliminally bring up the Olympics or something like that. And now I don't know how much of this is the reporter who wrote the thing and how much they actually got this information behind the scenes. But I think, I guess it's, you know, a lot of this is trade secrets, and I'm sure it has to do with renaming it will boost public interest in it and increase sales. It's got to be something like that.
Mostly adverse tissue, but also quite a bit of clean body. And so it's about a 3-to-1 ratio, adverse tissue to actual muscle. Like maybe before I do that, I would think I was counting. I'm going to like 30 minutes, hopefully trying to reduce.
Yeah, so the comment, if people couldn't hear it, has to do with these studies. These drugs don't only lead to adipose tissue loss, but also muscle mass loss. And has anybody seen, there's all this commercial stuff now of companies trying to market muscle boosting supplements for people that are on these drugs. So there's all this downstream stuff now happening because of, I think, what you said is becoming more and more well known. So let's build muscle while we're on the GLP-1 drug. And I think I even saw an advertisement for that somewhere. Yeah. So you're saying that actually you would or you do counsel patients about that?
I didn't change it much. Maybe not necessarily increasing muscle, but at least kind of.
Yeah. Yeah.
Is there any data that pump weight loss?
No, I would say that there's no long-term data for this drug. I could be wrong, you know, I don't see every study, but certainly for the earlier GLP-1 drugs, you stop the drug. There were studies showing people then randomized to stopping or continuing at a certain point, and the people who stop regain the weight. Yeah. Somebody wrote in, there are coupons on the Zepbound website that reduce the cost for the first year, and sometimes it's dramatic, but you know, that's all a commercial decision about how to get people prescribing, and then it goes up. And I've seen on, I saw on PBS NewsHour a few months ago, you know, people weeping. I got it for 25. This was for Wegovy, I guess, before this. For $25 a month for 6 months or something, and I lost all this weight, and then I went to the pharmacy and I had no more coupons, and I don't have insurance, and I regained all my weight. So, you know, there's a lot of stuff going on, which is why I think the cost thing we all need to be aware of. Okay, let's go on so I can stay on. What time it is. Okay, I think we're pretty good. Steroids for severe pneumonia. I don't know how many hospitalists tune in here, but as I said, I haven't done inpatient since 2019. So this is sort of like, you know, the view from the outpatient outsider. But this was an important study, and this addresses the controversy over whether steroids improve outcomes in hospitalized patients with severe community-acquired pneumonia. And, you know, there's been small studies over the last decade with varying conclusions or underpowered to really provide definitive conclusions. So this is from France, and it's a multi-center study that had 800 ICU patients. These were all patients admitted directly from the ER to the ICU with a median age of 67 with severe community-acquired pneumonia. And they had criteria for what counted as severity. There were like 4 or 5 of them, including a certain score on the pneumonia severity index, that standardized tool. If you were intubated, like in the ER, that counted as severe. And then there were PaO2, FiO2 ratios that you had to meet and so forth. 44% of these patients were intubated right at the beginning of the hospitalization, and 42% were on high flow nasal cannula. And they got either hydrocortisone, 200 milligrams IV daily, or a placebo. Importantly, treatment started very quickly in this study. It had to start within 24 hours of the patient meeting the severity criteria, which would be times 0 if you got him intubated right on arrival to the hospital, or a little bit later if the patient met those criteria a little bit later. But treatment was started in less than 24 hours of arriving at the hospital in just about everybody. And that's important because some of the older trials, which we're going to talk about in a meta-analysis in a slide or two from here, there were delays of up to 3 days before people got steroids. By the way, the 200 milligrams of IV hydrocortisone, if you remember the calculations, that's like 40 or 50 of methylprednisolone or prednisone daily. So it's moderately high dose, but not super high doses. Everybody got 4 days of the full dose, and then it was tapered over 1 to 2 weeks, depending on the clinician's preference about how the patient was doing. And 28-day mortality was the primary endpoint, and it was halved from 12% to 6% with steroid versus placebo, and that was statistically significant. Pretty impressive finding. For the patients who weren't initially intubated, remember I said 44% were intubated, so 56% weren't at the beginning. There was a positive finding for them too. They were less likely to require intubation, 18% versus 30% through the course of the hospitalization. Earlier meta-analyses of steroids for severe pneumonia failed to show a statistically significant mortality benefit, but a few months after this one, another one was published in Clinical Infectious Diseases that included this trial as well. The total N for the meta-analysis was 3,300. This French study had 800, so it contributed fully a quarter of the individual patients to the meta-analysis. A little over half of these, but it's a mixed bag, a little over half of the patients in the meta-analysis were admitted to non-ICU beds, so a little less than half directly to ICU. And in the meta-analysis, it comes up with a 30-day mortality of 6% versus 9%, statistically significant, favoring steroids. But in sub-analyses, the mortality benefit was limited to patients initially admitted to the ICU. For those admitted to non-ICU, the mortalities were less than this, as you would imagine. They're less sick patients. And there was a slight and barely statistically significant reduction in transfer to the ICU. It was something like 6 versus 4%. The trials, I looked at this meta-analysis and I looked at the abstracts of some of the component studies, and they're really all over the map, which raises, when you do a meta-analysis, what are you willing to put together? Severity of pneumonia is different across them. The steroid doses are all over the map. The timing of the steroids is different. So it's a little bit of a leap, I think, to confidently put them together. Clearly, this latest one is the best study, in my view, and in the view of experts, of this topic, of this issue. And then finally, the most recent guidelines from the American Thoracic Society and the Infectious Disease Society of America do not recommend, they talk about it, and they recommend against steroids for community-acquired pneumonia. Those were published like 3 years ago or something. It was one of those more data are needed discussions, unless the patient has refractory septic shock. So the question is, should the guideline change? Will the guideline change? And I assume it will. This topic was written up for Journal Watch by a critical care, an editor of ours who's a critical care person at the University of Washington. And basically, she wrote that, this latest French study will definitely, quote, lower my threshold for giving steroids in the ICU to patients who meet these criteria. She stopped short of saying every patient, so I assume there's going to be some individualization, but she definitely lowers her threshold. And she even says that, because who gets in an ICU versus who is managed on a floor is really sick, and just on the cusp of needing ICU probably varies from country to country, from hospital to hospital. So she felt that, for somebody with really, severe pneumonia by whatever criteria, you might make a case for doing it for that subset of patients who aren't even quite yet in the ICU. Anybody, I think that's all for this segment. Anybody have any personal thoughts or experience? Is everybody here outpatient? Yeah. Okay. Do people tune in who are hospitalists to this? Not too much? Yeah. Okay. So this doesn't really affect what we do in outpatient medicine. Nobody has any thoughts?
Just a quick question. Are there any adverse events?
Oh, yeah. Yeah, amazingly, well, not amazingly. I mean, you have a sick patient, all kinds of stuff is going on, and you give 200 of hydrocortisone, the equivalent of like 40 of prednisone for 4 days and then taper. You wouldn't expect to see anything noticeable. Yeah, this study and a couple of the larger studies in the meta-analysis see more hyperglycemia. But, a few days of more hyperglycemia, who knows, right? Didn't seem to affect the final outcome here. This study said no other visible adverse effects except noticing higher blood sugars. Good question.
I'm really glad you're presenting it, even though most of us are not. Maybe in patient setting, it's still good to know, and we advocate for our patients.
Yeah.
But, it's interesting to me, the person, wrote the journal launch review, or, which question, you mentioned one, institutions may have different kind of processes for when someone gets to the ICU. Yeah, it doesn't mean the same, but I think the other thing really, in my mind, that we probably is kind of which age patient, right? In my mind, just looking at like what happened with COVID-19, right? When it's severely there, people that not experience sometimes do more harm than good in fighting infection. Probably where steroids are going to have the most benefit, whereas people who can't maybe they're the ones that are suppressed or compromised, or they're very old and just not vulnerable response. So about as we each study always leads to another set of questions, further refine those, right? But anyway, a couple of things that come to mind. I would think about thresholds.
Yeah. I mean, it was a very nice response about all the things that might go into ultimately making decisions if you're taking care of this patient in the ICU or somebody who's really sick on the floor. And that's why I think there's enough issues here, being this one study and other studies didn't quite show this, although they were conducted differently, that there's still some clinical judgment about the, depending on the patient's risk factors, immunosuppression, all kinds of other things about whether to actually use it. So, okay. Perfectly on time here. I'll keep going. Testosterone safety. My first sentence there has two sets of quotation marks. Quote, testosterone therapy among, quote, aging men with, quote, low blood levels. And that's the patient population we're talking about. I think most people know why I put them in quotes, because what counts as aging here and what is the threshold for counting a serum testosterone level as low, right? We know epidemiologically, good data, that as we men get older, the mean in the population steadily goes down from age 40 to 60 to 80. So how low is too low? How low is pathologic versus the natural course of our lives? And I think that tension is underneath all of this stuff. But be that as it may, testosterone therapy is alive and well out there. And data on cardiovascular safety has been unclear. People have done retrospective studies that have been all over the map on whether testosterone supplementation in older people could be harmful or whether it's neutral. So in 2015, the FDA asked the drug companies that make these products to conduct a trial to examine cardiovascular safety. And a consortium of manufacturers got together and did that. So this is a drug company sponsored. This is not NIH sponsored or anything like that. It's called the TRAVERSE study. That's an acronym for testosterone replacement something something. I forget the other initials there. And it involved 5,200 men with age between 45 and 80 and a mean of 63. If a patient had like a concrete primary or secondary hypogonadism from a pituitary tumor or some known testicular disease, they were excluded from this study. These were basically men who say, could you check my testosterone? And there were 3 criteria to get into this study, 3 main ones. Fasting level between 100 and 300. You had to have 2 and they averaged them. The median here was 227, which we'll get back to in a moment. Quote, hypogonadism symptoms. To the best that I could figure out, if you read the methods and the online protocol, it was basically, they don't give like questionnaires. I think it was almost like a yes or no question. Do you have decreased libido? Do you have decreased erectile function? Do you have decreased energy? Do you have fatigue? And do you have any depressive symptoms? And if a person answered yes to any of those, you could get into the trial. And you see here, this is one quibble I've had with all of these studies. The big titles are men with hypogonadism. And then in the discussions, they say these patients had symptomatic hypogonadism, but a lot of us have fatigue and decreased energy and feel depressed sometimes. So it's an interesting issue here, but it does map onto what we're seeing and what patients ask for. So I guess in that respect, it's the all-inclusiveness is legitimate. The third thing to get in, this was a high risk. They wanted to see whether it's cardiovascular safety, and they enrolled patients with either known CAD, stroke, TIA, or peripheral vascular disease, and that was 55% of the enrollees, or people that had 3 risk factors, and that was 45% of the enrollees. And the risk factors, they wanted to get these, they wanted to enroll a lot of patients. It's a list of like 10 risk factors, and being over 65 counted as one of those 3 risk factors alone, so age was one. And that's the composition of the trial. They were randomized to 1.62% gel or placebo. The target testosterone was 350 to 750. Now, this is what I said. Remember, 227 was the median at baseline average. Averages during the trial with treatment went up, quote, only to, if you look at, there's a graph showing that during the trial, on average, the men on testosterone were in the 350 to 400 range for most of it. So it boosted it not by like 500 or something. It boosted it like 150 on average. The placebo group stayed exactly the same on average throughout the trial. Mean treatment duration was 22 months. Follow-up was 33 months. Why the difference there? It turns out that a large number of people in this trial stopped treatment for arbitrary reasons. They decided, I guess they didn't want to put on the gel anymore or whatever. In both the placebo and the testosterone group, something like almost half the people at some point stopped it before the end of the trial. So on average, people were on it for 2 years, but they were followed up for a total of 3 years on average. Another composite endpoint, MI stroke, cardiovascular death, it was exactly the same in both groups. 7%, and no differences in the 3 components of that endpoint. Also, overall mortality was the same in both groups. The one thing, if you look at the table of adverse effects, that's statistically significant is, quote, non-fatal arrhythmias. And I tried to find by looking, the supplemental index, and the only thing that I could find was that about 1 percentage point of that difference is atrial fibrillation. And the other 2nd percentage point of that difference, I'm not sure what kind of arrhythmias they're talking about. So there was a 1 percentage point higher risk of atrial fibrillation, which was statistically significant in a 5,000 patient trial, and total non-fatal arrhythmias, 2 percentage point increase. And they mention it in a couple sentences at the end of the article, and basically the gist is we're not sure what to do with that. Subgroups, no differences by age, whether you were over or under 65, the outcome, the cardiovascular outcome was the same in both the placebo and testosterone groups. And no difference by known cardiovascular disease versus the risk factor group, how you got into the trial. The outcomes were the same for those two subgroups with placebo or testosterone. So the conclusion from this part of the study is that in high-risk patients, 2 years of treatment with, and this is crucial, I think, with testosterone levels maintained on the lower side. These aren't people who, they were watched carefully. They're not like the people that I've seen in my precepting the VA who are going outside to men's clinics and their levels are 1,000 all the time. It appears safe from the cardiovascular perspective in those, with that caveat, this kind of population. Now, that was the end of what we had in our Journal Watch thing in December, but in December and January, there's been this explosion of other studies. These guys are getting lots of publications from this. While we're studying 5,000 patients for safety, we might as well look at some other things and publish it, right? Which is true, which is a good thing, because this is by far the largest, longest trial ever done of testosterone versus placebo. So just in the last 4 to 6 weeks, I've seen 4 articles, spin-off articles from this trial. In that first segment, these are spin-offs that involved all 5,200 participants. They track prostate outcomes because there's some concern about long-term testosterone therapy causing prostate cancer and affecting BPH. There was no difference in this study between the incidence of prostate cancer over those 2 years or 3 years, no difference in tracked lower urinary tract symptoms. The second one actually made it into the New England Journal a few weeks ago. Testosterone therapy in truly hypogonadal men is supposed to improve bone density. They didn't do bone density studies here, but that's from other studies. And their hypothesis is that this would reduce fractures. There was a statistically significant increase in fractures in the testosterone group. It's just 1 percentage point. And that 1 percentage point, if you look at the table, is spread. You can't say it's mostly this or that. It's spread out between hip and spine and wrist and humerus. Although toe, foot and digital fractures and skull fractures, things that aren't plausibly osteoporosis related, are not part of this endpoint. And they don't know how. If you read the discussion section, they're not sure how to. One person wrote, well, maybe the people on testosterone became more aggressive or something and then fell more and had fractures. I'm serious. I can't remember if I read that in the article or a commentator. Okay, and then 2 sub-studies here that were published in the Journal of Clinical Endocrinology and Metabolism in the last month. One was 2,600 men who got into this study had mostly mild depressive symptoms. They had PHQ-9 scores of 5 or more. And if you look at that, there's this tiny little statistical improvement in the scores on this, a different questionnaire they used, which I wasn't familiar with, that they admit is of questionable clinical importance. And then another sub-study was 1,200 men who reported decreased libido at baseline. And again, a very small statistical improvement in a questionnaire that looks at sexual function, again, of questionable clinical importance. And separately, they looked at erectile function. There was no difference in reported erectile function. So a few more of these sub-studies are coming out on other topics, probably in the next couple of months. So that's what we've got from the Traverse study. Questions, comments? question is, do we have any information about drug company funded studies versus non, right? And the only thing I can say, I mean, one would expect that the spin might be different, but the best study before this one was the testosterone trials, an NIH funded study back in 2016. And it's interesting, it sort of tracks these findings. This weird sexual function questionnaire, it's a 12-point questionnaire that asks about, a few of them are about partnered sexual outcomes, but a lot of them are sexual fantasies, masturbation. It's all over the map. And both in the testosterone trials, NIH funded, and this one, the testosterone group improved by a half a point. It was almost the same. So at least for that one, this drug company funded thing and the other one used the same endpoint for the sexual function. Now, the other things that were these sub-studies are not the same inventories as it, but the testosterone trials, the NIH one from 2016, it was the same thing showing, I think there were 3 sub-studies, sexual function, physical function, and something else. And there were either no statistical benefits or small statistical benefits. Like there was 6-minute walking was, 50 feet more with testosterone, and it was statistically significant. I'm making that up, but things like that where you look at it and you say, not so sure. So I would say that I would guess that we have to be suspicious about drug company funding, but for what it's worth, what I saw here in this depression and libido one looks about the same as what I saw in the NIH funded one. The other question is, in women, do I know anything about testosterone being given to women and safety? And I just don't know. Yeah. I have one more. Let's just see how. Okay, I can make that. Yeah. Steven?
I was going to say, first, I'm really interested about it. I think it is a market study. Then the patients were the amount of testosterone we got was less than. Did we think these outcomes would be pretty bad to prostate, etc., in a good response? The amount of testosterone given, well, then if 50% or more patients drop out, when would we expect to see those outcomes at the end? So I started thinking.
Yeah, I think the take-home point that Steve's making, for those who couldn't hear that, is what I sort of tried to imply here. This is a very restricted group. It's people at high cardiovascular risk who got testosterone for 2 years, which boosted their levels from 200s to 300s or mostly at 400, and it's only 2 years. So now here's the drug company. They're probably going to go out and say, hey, this is safe. But we have to look at who it was studied in. All right, let's race through the last one so we can finish at 9. Good point, thank you. We thought this was reasonable to, because statins are so ubiquitous, we thought it was reasonable to cover this one. Here we go. Atorvastatin, rosuvastatin, now obviously the most widely prescribed ones. And the questions here are there any difference in outcomes between the two? And is there any difference if we dose them in the 2 ways I'm going to tell you in a second? And this is a 4,400 patient study from Korea, South Korea, of patients with known coronary disease. Most of them were on testosterone. Most of them were on statins before this trial because they had known CAD, but they stopped whatever they were on and then entered the trial and got randomized. This is a double randomized 2x2 study. One randomization assigned patients either treat to target, starting with what's considered intermediate intensity, 10 milligrams of rosuvastatin or 20 of atorvastatin, and then titrating to the LDL goal of less than 70, versus starting immediately with high intensity, 20 or 40 of those 2 drugs. The second randomization was within each of the above groups there, randomly assigned to atorvastatin or rosuvastatin at the appropriate equivalent doses. What they found was at 3 years, the treat to target, this was a non-inferior study, had outcomes, death, MI, stroke, or revascularization, this primary outcome, inferior to high intensity. Numerically, it was actually a little bit lower, the incidence of the outcome with treat to target. The mean LDL was the same in both groups, 69. And half the treat to target group ended the study still on moderate intensity, did not, quote, have to be titrated up. Now, that doesn't make sense if you're looking at this, because if the mean was 69 and the target was less than 70, that means something like half of them still were over 70. And I couldn't figure that out, and I didn't really see that addressed. But somebody was a little gun shy, apparently, because you could add, later in the study, you could add ezetimibe and other, if the clinician felt it was necessary. So they still remained with some patients above the 70. For the atorvastatin versus rosuvastatin comparison, there was no difference in that primary clinical outcome between the two. LDL levels were similar. But the one thing that was highly statistically significant different was that there was a higher risk of new onset diabetes with rosuvastatin. Now, you probably know that in meta-analyses or systematic reviews, it's pretty well accepted. I think it's accepted that there's a small 1 or 2 percentage point increase in the incidence of diabetes in long-term statin users. And there's some molecular mechanisms and cellular mechanisms that I read about in the past and can't repeat, don't recall, but that's been shown, and that's considered to be a side effect now. And for what it's worth, it was higher with rosuvastatin in this study than with atorvastatin. So I suppose that could be a tiebreaker if you were sitting there trying to decide which one, and cost was not an issue. There was also a higher risk of cataract surgery, which was statistically significant, just 1 percentage point though, with rosuvastatin. That's been discussed as a potential side effect of statin therapy in the literature, controversial, if it hastens cataract. And I guess it's 8:57, so anyway, I think as a tiebreaker, maybe I would use atorvastatin now in preference to rosuvastatin. One question, yeah.
I'm trying to make sense of the fact that treatment target is non-inferior. How does that remain on moderate intensity with that same need? So is there more consideration for side effects in the high intensity group that started off like, are there more myalgias?
Allegedly not. If you look at the table, the sort of like, the subjective side effects, myalgia stuff, were about the same. Were the same in both groups. I thought the same thing and I looked at it. So, a lot of it in the business with the mean and how they titrated it, a lot of it doesn't make sense, right? On the other hand, I think the diabetes thing is sort of, people forget about that. And so I think that it's a large enough study. That was highly statistical significant. Is it the final truth of the matter? I don't know. Probably, you could say that in the end, it doesn't matter. Like, limitations. Yeah, okay.